All right, well, good afternoon. We are extremely lucky today because we have Dr. Aftab with us today. He is a true expert coming all the way from Surrey in London, and he's an expert in skin involvement connected with Wilson's disease.
Okay, so it's a great pleasure to be here. It's fantastic to be meeting some of you. Hopefully I'll meet more of you during the day. I'm going to share with you my experiences of Wilson's disease and skin over the next 20-30 minutes. Would very welcome some questions and your own experiences. So I'm a hepatologist. I work at King's College London, and I've got 20 years of experience within the field. The skin area is something we all forget, but actually it's there in front of our very eyes. And it's a challenge which I'd like to remind you of on a day-to-day basis. So these are my disclosures. So as an introduction, there are many manifestations of skin and Wilson's disease. Whether it's related to Wilson's disease or whether it's related to the treatment remains to be determined. So that these are a number of skin manifestations, as you'll see. And these manifestations are well documented in association with Wilson's disease. They are changes related to progeria or premature aging, and it's called cutis laxus in medical terms. Then there is elastosis perforans serpeginosa, and then there's lichen planus and aphthostomatitis, which can affect the mouth and the gum areas, and then lipomas or lipid deposits throughout the skin, and then pemphigus. These are superficial skin areas throughout the body. And I'm going to start off with this manifestation, which can occur usually around the flexor surfaces, usually around the neck or around the axilla or around the groins. And usually this area appears, as you can see on the top left, with a central clearing. You can see a rash, but with an empty area in the middle. And then over the months, the lesion can become raised and it can become very itchy. And if you take a biopsy of that area, you can see a fiber called elastin, which congregates in the skin and forms a nodule. And over the years, the nodule can burst, right? So think about this type of problem in lifelong medication. And then this is a manifestation which we probably do see, but we may not necessarily pay attention to. So this is early pigmentation. This is hyperpigmentation of the skin that can occur on the back or usually on the lower legs, all right? And sometimes this can be seen in early cases of Wilson's disease, all right? And more often than not, it can be associated with neurological disease. It's generally associated with increased pigment or melanin within the skin. And certainly in a number of cases that have been described in the scientific literature, almost 60% of patients who presented Wilson's disease have this hyperpigmentation. As you can see, typically the pigmentation can occur on the legs or on the back or in the very lower legs like the ankles. So be aware of these manifestations. And then this is another series of manifestations where you can get this lesion called lichen planus. And it's a scaly lesion which can occur anywhere in the body, but in particular it can be on the back and on the lower legs or on the upper limbs. And you can see these are slides that have been lent to me by my colleague, Dr. Tlenska and Dr. Medici from Poland and United States. And they've described these areas at the back and also lipomas in the lower back and on the neck. And I've seen these on my own, where I've seen an increased association with Wilson's disease and particularly chelation therapy. This is something that you probably do see on a day-to-day basis, but you're not aware of it necessarily. And in my experience, these changes have usually occurred in patients who've been on lifelong chelation therapy, particularly penicillamine. So beware of these type of changes. Something that, so for example, in the top left, this was a man who always came to clinic with a tie on, right? And I missed this because he always came in a jacket and a tie. So as a clinician, I always made it very important to undress him and look at the skin, both in the front and the back. So as a clinician, we're always taught to examine the patient. This is what we do, right? This is why we examine the patient. And when I examined him, I found that even in his 50s, he's 70 in that slide, but even in his 50s, because he'd been on penicillamine, top left, for almost 40 years, and he developed this premature aging, right, particularly of his neck area. And then the lady on the slide 2, there was these premature aging at the back of the neck, and she used to always come to clinic with a scarf on, and I wondered why she was wearing a scarf. So I asked her to undress, and behind the scarf there was these lesions, right? And then the third slide was of a lady who'd said, look, she'd become had increased in weight rapidly. But when she went on Mounjaro, right, the GLP analogs for losing weight, I found that she'd got very, very, very premature aging of her skin in the lower back. And as you can see, the bottom left are those changes which can't just be due to weight loss. And then the fourth and the fifth slides, these are permissions which I've got from patients to show this to you, where again you can see premature aging of the skin, particularly on the neck. And then on the facial area, you can see quite pronounced on this lady. If you took the glasses off, you can see these areas of premature aging. So we don't know why this premature aging occurs. We think it's probably because of degeneration of the fibers in the skin, but it's certainly recognized in long-term penicillamine therapy. And there is various scientific mechanisms as to why there may be increased collagen or abnormal collagen. And one of those theories might be that there are protein residues, abnormal protein residues, which collect within the skin, and they are called lysine residues. Secondly, it may be due to local copper deficiency within the skin. That's a possible hypothesis. And it's interesting, there's a neurological condition called occipital horn syndrome, where you get almost identical skin lesions, right? And it's related to copper deficiency. So we think there may be a possible link with occipital horn syndrome and these skin lesions. But it may be, rather than too much copper, we think the skin lesions may well be due to local low copper, i.e. copper deficiency. So this is a series of slides which were given to me by the UK Wilson's disease support group. And you can see this is a mixture of elastocytosis perforans serpiginosa with cutis laxa. So there's two skin lesions. The first lesion on the left, you see the elastocytosis perforans on the back of the neck. And then with that, there's a migration into the back of the neck, into the hairline. You can see that quite clearly. Because we didn't know at the time how to treat this, because it was very unsightly and very painful, my clinician colleagues, they decided to apply cryotherapy to freeze that area. And after 10 years, you can see that the elastocytosis perforans has disappeared, but the cutis laxa is more pronounced. Yeah? I hope you can appreciate that. So I'm going to describe to you a case of a 45-year-old male who came to my clinic at King's, who was diagnosed at the age of 9. And he was diagnosed because his elder brother also had Wilson's disease, and he was not doing very well at school. And I've heard today from a number of people who I've talked to that sometimes, even at the age of 9, the diagnosis can be delayed because children are not performing well at school. Anyway, he was diagnosed at the age of 9. He got started on penicillamine, and he'd been on penicillamine for over 20 years, but 10 years of stable disease. And he actually developed cutis laxa. So you can see this, where he looks older than he is, actually. He looks much older than he is. So you can see the typical wrinkly neck. And if you look at them more closely, it's very, very wrinkly. In fact, it's not wrinkly around the neck, but also around the axilla, around the armpits. So this led us to believe that there was a problem, right? It wasn't just fate. There was a significant problem. And so what we did was we biopsied the skin, right? And when we biopsied the neck area and the armpits, we found these typical areas of clusters of elastin fibers. And you see these typical changes where the elastin fibers become very, very thick, and they're very noticeable. It's almost a characteristic hallmark of early aging in this process. So you can see the elastic fibers on the right side, that they're thickened, and they're fragmented, and they're serrated. So these are the hallmarks of a biopsy when we look at it under the microscope. So it's very important to do a biopsy. If you're not sure, you do a biopsy to confirm these skin changes. Because otherwise, it'll just be your impression. So this patient was switched to zinc, and then he was back on penicillamine after development of cirrhosis and decompensation, which meant that his liver was almost falling apart in front of our very eyes while he was on zinc. And he remained on penicillamine, and then he recompensated. So his ascites and encephalopathy over 2 years actually got better. So his disease, liver disease, actually got better with reconstitution of treatment. So we decided, because we'd found skin lesions, we couldn't leave this patient on penicillamine. We had to do something different, right? So we actually switched him to trientine. But just before we switched him to trientine, we did an ECG, as part of normal standard of care. And to our surprise, when we did an ECG, we found that his aorta, which is the big blood vessel, which surprised the rest of the body, the aorta blood vessel was enlarged, abnormally enlarged. And we then did an MRI. And MRI technology is fantastic because it allows us to characterize what's going on in the blood vessels. And to our surprise, we found that his aorta was huge. In fact, he's got huge aortic root dilatation, abnormal aortic root dilatation. And had we not picked that up early, the blood vessel would have burst and he would have probably died. So with this case underlies to you that there are skin changes in patients who are on long-term therapy. We don't know what the mechanism of action is, and the subsequent change in management, in other words, what we do to change therapy, is not necessarily evidence-based, but it's probably our best guess. We think the cutis laxa is probably seen in other conditions in medicine. So, for example, there's a condition called pseudoxanthoma elasticum, which is associated with aortic root dilatation. So we think the mechanisms of the disease is probably related to pseudoxanthoma elasticum. Now, this is a patient, found this patient only 6 weeks ago, so I've described to you long-term penicillamine treatment and the possible unwanted effects from that. I'm now going to describe to you a rash which I thought I'd never ever see. So this was a patient who had been on, it was an air stewardess, 31-year-old air stewardess, who was 31-year-old, and she'd been on zinc for many years. She became intolerant to zinc with abdominal pain, and her physician had put her on penicillamine. She then became intolerant to that with a rash. So then she came to see me and said, look, what could we do different? So I decided to put her on trientine. And to my surprise, within 6 weeks of trientine, she developed the rash you can see around the left arm. I couldn't think of anything else other than a possible drug allergy, which I thought was very unusual because I'd never seen it. It's only been described in the literature. And actually, to my surprise, again, I did a biopsy. This is the value of doing a biopsy. To my surprise, I found typical allergic responses from the trientine. So immediately I stopped the trientine, and now I'm in a position, I don't know what to do because she's already been on penicillamine, she's not tolerant to zinc, or she's intolerant to zinc, and now she's had an allergy to trientine. Whether I swap her to another form of trientine remains to be seen. So the implication of the skin and Wilson's disease is enormous. Can we correlate the skin with what's going on in Wilson's disease? So it's important that we recognize early what's going on with the skin. And if we're not sure, we biopsy the skin. It's important that there are recognition of vascular changes, i.e. maybe consider echo or MRI to look at the blood vessel changes in people who are long-term penicillamine who develop vascular changes. Now, whether the skin lesions come because there's inaccuracies of monitoring, it's a possibility. Because at the moment, before the EASL guidelines came out, we really had no idea about how to monitor the patients. And possibly, as our speakers have described, with the relative exchange of copper, these methods may improve monitoring. And so there is further understanding of this area, to be characterized. So whether the causal factor is because you've got a low serum copper, or because there's a low copper within the skin, or both, or other, remains to be determined. We don't know. We don't know how should we manage these patients who get skin lesions, right? We don't know whether we should stop the therapy or reduce the dose or change to another therapy. We don't know that. And then how should we monitor the treatment? Should we monitor the treatment? Should everyone be getting either accurate NCC or exchangeable copper? Probably yes. We should all be doing relatively exchangeable copper to better monitor the patients so that we can prevent the skin changes. And this is where the new EASL guidelines will become very useful. So the possible approaches to this type of problem could be that, as I said, I've described to you skin lesions, whether do we stop the penicillamine, do we reduce the therapy, or do we reduce and then stop? Most important thing is to document those changes. So you've got those changes there, rather than just saying, oh, you may have it. So it's important to document those changes in the notes and then move on. Now, on a scientific level, we're looking at certain enzymes within the skin and within the blood. And one of those enzymes, we're looking towards a formal study to look at lysyl oxidase, which is linked with a reduction in copper. And at this moment in time, we're developing an international consortia to look at skin changes and long-term treatment, really because we need the evidence base. And much of our practice sometimes is not necessarily evidence-based, but there is increasing evidence now in these areas. Thank you very much.